Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Feinberg School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Welcome to ModPath Chat. My guest today is Dr. Xinyan Lu, professor of pathology and director of clinical cytogenetic service at Northwestern University Feinberg School of Medicine in Chicago. Dr. Lu is an expert in genetics and genomic analyses of hematologic and solid tumors. Today, we will be discussing her multi-institutional study on ROS1 alterations as a potential driver in gliomas. And I want to emphasize the multi-institutional nature of the studies. The three first authors, I would like to credit, David Meredith, Linda Cooley, and Adrian Dubuc, are from Harvard and Brigham and Women's Hospital, as well as University of Missouri School of Medicine. And to my pleasant surprise, some of the authors are from UPenn, a great colleague of mine. So welcome, Xinyan, and thank you for accepting my invitation.
Good morning, Dr. Netto, and thanks for the opportunity and for inviting me to join today's podcast. I'm very, very honored to be here to maybe speak a little bit about our recently published study at the Modern Path. And I know, I have been really very, persistently a publisher actually at the Modern Path in the past, and I love this journal very much. So I'm so happy that I can share my experience with you regarding the study and with all the audience.
Wonderful. Yeah, you serve as a good ambassador for our journal, and we really appreciate this is another amazing study, and hence I wanted us to spend a few minutes talking about it so our audience can benefit. So I guess most of us are familiar with ROS1 in lung, although it's really a rare occurrence, ROS1-driven lung. But reading your beautiful paper now, I learned even in extrahepatic cholangio and gallbladder is actually more frequent. Around 15% of these tumors are driven by ROS. But I didn't know anything about ROS and brain tumors. So tell me what motivated you to do this study, and so we can start the conversation.
Yeah, so this all started from a single patient in my institution. Actually, this young man was 27 years old, and he accidentally fell on the floor, and then we sent him to the ER, then did all the workup, MR and CT, and certainly they found this person actually had a tumor in the brain. So it's like traumatic bleeding, but also with a tumor. Then they did a subtotal biopsy and confirmed with a GBM diagnosis. So at our institution, usually we do a comprehensive workup of the brain tumor for the molecular characterization, including, the OncoScan-based assay for copy number analysis and also NGS-based testing. And sometimes, of course, we do FISH. And also a bunch of the IHC following the brain tumor clinical workup, the existing one. So for this particular patient, when we did the OncoScan, we found a small change at the chromosome 6q that the microdeletion resulted in a ROS1 GOPC fusion. So when I saw this result, I was like, interesting, because I used to work for, non-small cell lung cancer quite a lot. I developed and validated ROS1 FISH testing in my current lab. Also in my previous lab, I was the section chief at MD Anderson Cancer Center, and also developed the test over there. And I said, ROS1 in non-small cell lung cancer is targetable, but I never heard about it in adult GBM, and what are the clinical implications of the study. So I looked up, of course, to see if there are any reports available for the ROS1 fusions in adult cancer. And certainly there are many of the solid tumors. We're talking about 1% non-small cell lung cancer, and probably like 10 or 15% the gallbladder cancer, maybe 1% the ovarian cancer. But really the overall frequency in the brain tumor, no, not known at all. Mm-hmm. So then I happened to have some colleagues in the Cancer Genomics Consortium. So I just sent out a notification. I said, hey, I have an interesting case with brain tumor ROS1 and GOPC fusion. If y'all have any cases, we can put together for a maybe serious case report or something like that. My original point is just to see if we can publish as a small serious case study. And so it took us a little bit of time, and we were able to through a multi-institutional collaboration, and we were able to collect 32 unpublished cases. So right. Our question wanted to ask is, first of all, what is overall frequency of the ROS1 rearrangement or fusions in brain tumor? Is that enriched in specific age group? And what are the clinical implications? And also importantly, because we know many of the gliomas, diffuse gliomas, particularly in adults and also in a small infant, it's very deadly disease. And we wanted to see, given that the ROS1 is targetable in non-small cell lung cancer, if there are potential, possibilities of a trial maybe also be targetable or this type of patients. So we had so many questions. We wanted to see what can we get. That's how the study, initiated.
Beautifully put. So it's so you already touched upon that. The partner in this specific case, the fusion partner is GOPC or GOPC, which the GO refers to Goldie, just for our audience. And you had 32, you managed to find 32 cases. You thought you're going to do a case report, and I'm glad you didn't. So 32 cases, and you also reviewed the literature, so included some previously published cases. And I'm reading here is 58 published cases. So your total is a huge number, 90 cases, but this is considering it's almost a national study. While 90 is a lot, it's the denominator is very large, and so they remain rare. So, and you touched upon the technology that you used. Is it the same technology across all? I realize some of them may have been done in different places, so maybe the molecular panel was different. But you did NGS and FISH and OncoScan, and what else?
Yeah, so that's a very great question. And this also, I want to emphasize, I will come back to this point, when I finish with this question. So first of all, yes, we had 32 new cases that are unpublished from 10 institutions nationwide. And from these 10 cases, actually, even though all cases are done, did a biopsy or maybe definite surgery, and also had all the pathology available, but not all cases are performed comprehensive genomic profiling or mutational profiling. And depending on the case, it was collected, and depending on the available of the clinical testing and the clinical settings. So at our institution, we had the privilege that we can perform the comprehensive genomic profiling, I call CGP, that is recommended by ASCO, particularly the CF for precision medicine. So meaning that we do want to have a comprehensive assay, it can be single assay or multi-assay combined for detecting those recurrent mutational profiling, copy number aberrations, or maybe even methylation signature and gene expression profiling. And sometimes it can be a, single FISH-based testing based upon, the tissue availability or tumor cell content. So best bet is what is the best approach for this kind of clinical workup. So of these 32 cases, like I said, from 10 institutions, not all cases are done with this CGP comprehensive approach. Some of them only had FISH assays. I had an infant, previous infant GBM, but now is an infant hemispheric glioma, only had the FISH was done. And I had some of the cases, like from UPenn, for example, had the next generation sequencing identified as recurrent the mutations and some of the copy number assays. And also the cases from Brigham Women, Harvard, they all had a comprehensive approach as we did. So there are some variations going on. Yeah. So our point I wanted to make at the end of the study is because given that there's a variety of the tools clinical laboratory, we wanted to see what is the best for this kind of clinical workup and how we're gonna help identify these ROS1 fusions, for example. So we were thinking about maybe we can show the study, we can come up with a sort of a guidelines at the end. This kind of approach, actually, we did make some points in our paper.
So we'll revisit that at the end. So it sounds like part of the motivation was that, well, this is known rarely in infant, and I think in the WHO is mentioned in the infant population. It wasn't as known to be in older patients. So you went ahead and divided your group into infant, pediatric, and then adult population. And it seems like to focus on your findings, there's some differences among the three group or not, both in molecular and clinical outcome.
Yeah, so because we only had 32 patients non-published, and we did identify there are three groups, like for the infant, I think we're, a handful of patients in the pediatric patients and the majority in the adult. So we did a meta-analysis by reviewing and all the literature published cases, and we were able to identify 58 additional cases that were actually published in the literature. So then when we combined our 32 cases with those 58 published cases, we were able to actually group or the entire cohort into three different age groups. So the infant type, and we had like 19 patients in the infant type, and we had 40 pediatric patients, and we had 31 adult patients. So this has become a reasonable cohort. Then we can do, all the different analysis and with some of the available information from both the new cohort and the published cohorts, we were able to collect NGS data or copy number assay and some of the methylation data and even some of FISH data. And then we were able to combine all the data, additional data, and to define if there is any characteristics among these three groups. So to quickly, briefly summary our finding is, we found that in the infant group, however, seems like ROS1 is a major event. Very few cases with additional copy number aberrations or maybe with mutation, recurrent mutations that are identified. So we sort of concluded ROS1 could be a major driver in the infant group. And in the pediatric group, pediatric consists largest, patients in this cohort. And we found, compared with infant, there is increased copy number aberrations and some of the, mutations. But however, it's just moderate genomic complexity. So when we analyze the 31 cases with adult, and we, found there are a lot more genomic events, and including some of the recurrent copy number aberrations like 7, monosomy 10, or CDKN2 to be homozygous deletion, and the TERT promoter mutation or T53 mutation, and also others involving like CDK4, MDM2 amplification. Those are the recurrent events actually often seen in adult typical glioblastoma. So we found that, as age increase, seems like genomic complexity, increased significantly, particularly when in adult patients. So we sort of draw a conclusion while the ROS1 is considered as the primary drive in infant type. It could be a primary drive or maybe co-drive in pediatric patients, but definitely there are also ROS1 plays a very important role in the adult patients, could be a co-drive. So these kind of, finding, we were able to, further sorting them out.
To draw, molecular pathologic conclusions about what are the drivers in each subset. But I think equally importantly, there was differences in outcome, right? And in the morphology too.
That is right. So we did look at the morphology comparison histologically. I think the infant type, certainly there is a, high grade features, whereas a pediatric type, there is like a variety of the difference between primarily low grade, but there are also some of cases with high grade, whereas adult type, they are uniformly GBM. So it's very high grade histologically and the morphology. So it's really very distinctible, actually, based on the morphology. Certainly the clinical outcome, even though we had limited cases in infant type, but it seems like pediatrics have the best clinical outcome, whereas adult patients in the infant type, they are just poor than the pediatric population.
Excellent. So it's bad in adult, more complex molecular. It has even a lot of features, molecular features that you associate with GBM. It did look like GBM. So these are all clues. But I guess in order to identify something as ROS, you're still going to need to have a high index of suspicion, but even that probably doesn't help. You need to do all the standard molecular analysis to discover the rare subset that is ROS1 driven, correct? Is that a fair statement?
Yes, that's right. So given our findings and also given, the comparison we had with current WHO, the CNS tumor classification, where they only, like you mentioned earlier, they only put an infant type hemispheric glioma with ROS and the MET rearrangement as a subtype. And there is actually lack of the data to support prior publication to support there is a ROS1 fusion. It is a recurrent and also not a rare event in the pediatric patients and also in the adult patients. So thinking we just probably also mentioned this in this approach in our paper is probably previously we do not have a standard guideline to be implemented, how we're going to do a consistent workup for this. For example, maybe we should target or maybe just to implement the ROS1 testing specifically in adult cancer, like we did in non-small cell lung cancer, for example. We always do FISH-based testing in addition to the IHC, for example. But for the brain tumors, there is no such guideline available, and to make people aware that there is a need potentially for the ROS1 testing. So our data suggests that maybe more people need to be aware there might be a need of the testing, because based on our internal data and also based on the internal data unpublished from Harvard, the overall frequency could be from 0.5% to 1% in brain tumors. And this is comparable, compared with 1% of the occurrence in non-small cell lung cancer. Certainly the denominator in non-small cell lung cancer is much larger than the gliomas, but this is still considered as significant. So we're thinking probably we need to come up with a potential guideline in the future, and our data can be cited, to support such of the guideline and to see if there is a need of implementation of the ROS1 standard clinical testing.
Beautiful. And it's really very critical. And this is an example of a very impactful study. Studies, when done right, and big cohorts, multi-institutional. And so the end result is this will impact probably the WHO classification the next series. And most importantly, albeit it's just 1%, for example, of GBMs, that's a deadly disease, and finding a target that can be targeted by crizotinib, in this case for ROS, that could be tremendous for our patients. So great work, and I really enjoyed the conversation. I learned a lot. So thank you for coming again, and I really appreciated it.
Well, thank you, Dr. Neda, for the great opportunity. I just want to mention one more thing is because currently there is no preclinical trial and clinical trial targeting ROS1 for brain tumors. I hope our work will make this possible for the future clinical trials for those people actually diagnosed with ROS1 fusion brain tumors, because the third generation of the ROS1 target, the drug is called alatinib, we mentioned in the paper. This drug can go through BBB, brain-blood barrier, and this could be very effective targeting ROS1. So I really hope, our work will be helpful for treating those patients with targeted therapy to save their life in the near future if these people are identified in time. So this is really our, potential hope. And I want to thank you for giving me the opportunity to share our work with you and with the journal.
Thank you. That will be a tremendous, and hopefully they'll respond, and we'll await those trials, and maybe it get published again in Modern Past, some of the population that was treated in the future. So thank you again, and to our audience, if you enjoyed listening to the podcast, don't forget to tune in to our USCAP YouTube channel, where you can actually see Dr. Lu and re-listen again to the podcast. Thanks again.
Thank you, Dr. Neda.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.